Welcome to Fibroid Awareness Month 2024. I'm Sateria Venable, founder and CEO of the Fibroid Foundation. The theme for Fibroid Awareness Month 2024 is the fibroid maze, navigating a complex diagnosis. Fibroids do not just mean that you have a bad period. Fibroids can affect many aspects of our lives. Throughout Fibroid Awareness Month, we'll delve into many aspects of fibroid care. Many of the topics are a result of your feedback. The following topics will be discussed in expert panels: quality of life, can fibroids mask other issues, fibroids after 40, and pregnancy after fibroid surgery. Thank you so much for joining us. We look forward to sharing valuable information with you so you can be prepared to discuss your treatment plan with your healthcare provider.
Hello, I am Jermaine Reed, and I'm a board member of the Fibroid Foundation. Thank you so much for joining us during Fibroid Awareness Month, centered around our theme, the fibroid maze, finding solutions for a complex diagnosis. In addition to being a board member, I am also a fibroid warrior. I was diagnosed and had surgery in 2020 to remove most of them. Early in my diagnosis, I found the Fibroid Foundation through social media while searching online for answers at 2 a.m. From the beginning, I felt genuinely supported through the Foundation's free education resources, access to the latest peer-reviewed research, and an extensive network of global ambassadors who volunteer their time to offer guidance and support from their own fibroid experiences. We hope you enjoy the programming created for you throughout this important month. We invite you to donate so that we can continue to support everyone in need at thefibroidfoundation.org. Join me in supporting the Fibroid Foundation. Together, we can make a difference.
Hello, I'm Sateria Venable, founder and CEO of the Fibroid Foundation. Welcome to Fibroid Awareness Month 2024. This segment is called Pregnancy After Fibroid Surgery. Thank you for joining us for this important conversation. Many women who are diagnosed with fibroids want to have children. When discussing their treatment options, they're unsure which treatment option to choose. We often receive questions on which surgery is most appropriate for a healthy pregnancy and delivery. Today, I'm so pleased to be joined by Dr. Jeannie Kim and Dr. Rachel McConnell, who will give us insights on this topic. Dr. Jeannie Kim is an associate professor of obstetrics and gynecology at Columbia University Irving Medical Center in the Division of Gynecologic Surgical Services. Dr. Kim is a graduate of Yale and earned her medical degree from New York University. Following her residency in obstetrics and gynecology at New York University, she completed an AAGL, which is the American Association of Gynecologic Laparoscopists, accredited fellowship in minimally invasive surgery and chronic pelvic pain at the University of Michigan, also earning her master's in clinical research design and statistical analysis. Dr. Kim is also the chair of the Fibroid Special Interest Group for AAGL. Dr. McConnell received her medical degree from Louisiana State University Medical School. After completing her residency in obstetrics and gynecology at Tulane University Medical Center, she successfully completed a fellowship in reproductive endocrinology and infertility at the University of Southern California School of Medicine. She served as chief of the Division of Reproductive Endocrinology and Infertility at the University of Nevada School of Medicine, Las Vegas. And as chief, Dr. McConnell was instrumental in the successful development of the University Institute for Fertility. Dr. McConnell joined Columbia University as an associate professor in 2012 and has a special interest in ovulatory disorders, tubal disease, fibroid disorders, and ovarian aging and fertility preservation, as well as in vitro fertilization and egg donation. Dr. Kim, Dr. McConnell, welcome, welcome, welcome. It's so wonderful to have you both on the panel.
Thank you. Thank you so much for the lovely introduction.
Thank you.
Well, I'll just jump right in because this is a question that we receive from viewers all over the world, asking about the possibility of conceiving after a fibroid diagnosis and or procedure and how to navigate that process. So our first question is there a specific provider that a woman should ideally see if they have fibroids with the goal of conceiving? And I'll come to Dr. McConnell first with that.
It all depends. That's a very good question. And it all depends on the location of the fibroids. It could be also depends on how large the fibroids are and how many fibroids there are. So there are procedures called hysteroscopic myomectomies. That procedure is geared toward women who have fibroids that are localized inside the uterine cavity. There are some fibroids that are only located in the cavity, and there are some fibroids that originate from the muscle and begin to protrude into the uterine cavity. Those fibroids are usually removed by hysteroscopic procedure as well. There are fibroids that are more involved in the uterine cavity. More involved in the muscle of the uterus, I should say, and barely touching the lining or distorting the uterine cavity. Those fibroids should also or could be removed hysteroscopically. And then there's other procedures, laparoscopic myomectomies, abdominal myomectomies. But I would say in our practice, mainly if it's more localized in the uterine cavity, it would be a hysteroscopic approach. And usually we will refer our patients to our GYN team with Dr. Kim and her colleagues because we know and we all work together that we want to do procedures that are very sparing, and we know that those doctors are going to consider that our patients are trying to preserve their fertility. And I think that's very important when you are in need of a surgical procedure, is to make sure that you are with a physician that has your best interest in trying to preserve and be as meticulous as possible, decreasing risk factors that can decrease their chances of getting pregnant after the procedure. So those would be the best procedures, a hysteroscopic myomectomy or a laparoscopic myomectomy, and in some cases, an open myomectomy, depending upon how many fibroids, the location, and the size.
And Dr. McConnell, can you describe for our listeners what a reproductive endocrinologist is? Because it's my opinion that specialty is very important in terms of fibroid care, and it's not a specialty that is well known to most patients.
Okay. A reproductive endocrinologist and infertility specialist is a doctor after the patient has pretty much tried to conceive for at least a year, depending on their age. And some patients who may be older, 35 years of age and older, that would like to conceive and they have not conceived within a 6-month period. Those are the patients that we typically would see. We are doctors who are geared toward helping patients reach their goals of adding to or starting their families. We also not only do procedures such as in vitro fertilization, we do procedures such as this, hysteroscopic procedures, but like I said, in more involved procedures, we typically will refer them to our GYN team. So to sum it up, a reproductive endocrinologist, we're looking at the whole reproductive system as it relates to infertility. We're looking at hormonal issues as it relates to infertility, anatomical issues such as fibroids or other issues that may be going on with the uterus, And we are offering services such as ovulation induction with medication to help patients conceive, and other procedures that may be not as aggressive as what we call intrauterine insemination, and to the point of advanced technique of treatment such as in vitro egg donation, and for women who may not be ready to start their families, but they are well aware that as women will age, the egg count and their egg quality will begin to decrease. So in those patients, we're offering fertility preservation. So we also look into the future to try to help guide patients with egg freezing and in some cases embryo freezing.
Okay, I
What-
have a quick, go
I
ahead,
want to
Dr.
just
Kim.
piggyback on, the important role that Dr. McConnell and her team and specialists like Dr. McConnell have. But I just wanted to also just take a step back and say that, your primary OBGYN is sort of, you can think of as your gatekeeper. And so, I think I just want to stress how important it is to maintain well woman visits, routine screening, even if you weren't necessarily thinking of fibroids and the fertility implications necessarily. I think as many of you may already know, that fibroids are extremely common in the United States, and the number is quoted up to 80%. And so a lot of women may have fibroids, but they may not know that they have fibroids. Maybe they don't have symptoms. And sometimes these fibroids can be picked up because of symptoms, but I think it's very important to make sure that you do follow up with your primary OBGYN, who can screen you for symptoms, do your annual pelvic exams to see. I do see a lot of patients who say, oh, I didn't really feel much, but oh, I had this large mass that was felt by my OBGYN, and here I am, I have a 10-centimeter fibroid, and I think I want to get pregnant, and now what do I do? And so sometimes these scenarios come up. And of course, there are times when symptoms are the predominant driver of seeking medical care. But I would think of your primary OBGYN as your gatekeeper, screener, who can actually make the diagnosis and then direct you to who you do need to see, depending on your fertility goals and some of your symptoms. So as Dr. McConnell mentioned, certainly you would see a fertility specialist if you haven't been able to get pregnant within a certain amount of time. Sometimes you might be referred to a gynecologic surgeon like myself if you were deciding to do some type of procedure. But there are also other specialists outside of OBGYN as well that you might encounter. For example, if you were deciding on other treatment options like uterine embolization or MR-guided ultrasound or MR-guided focused ultrasound, then you might see an interventional radiologist. Sometimes people do come in with extremely heavy bleeding who might have significant anemia. So you may be referred to a hematologist who might discuss with you iron treatment options, whether it's oral, intravenous. Hopefully you don't need any blood transfusions, but some of these other providers, you might encounter in your path.
Dr. Kim, thank you for that clarification. And that's so incredibly important. In fact, during one of our segments this month, we are actually talking about the importance of screening. So I'm so glad that you raised that as a really, really important step to take. And it's really good that you mentioned coordinated care. Can you speak a little bit about coordinated care? For instance, if someone were to come to you as their obstetrician gynecologist and they needed to see an interventional radiologist, isn't it very, very important for them to still receive a full gynecologic consult?
Yes, absolutely. So just to clarify, there are primary OBGYNs who practice obstetrics and who would do the deliveries. And I actually don't do primary obstetric care. But in any event, certainly screening with biopsies if it's indicated, pap screening just to make sure all of your other, non-fibroid related screening measures have been up to date. I think those are extremely important. And like you said, if you were being referred to an interventional radiologist, the first thing they will probably want to make sure is a negative endometrial biopsy, especially if you are of a certain age.
That's very, very important for everyone to take note of, to make sure that you're receiving comprehensive care. Are there treatments that should be avoided if the goal is to become pregnant? I'll come back to you, Dr. Kim.
So that's sort of a complicated question or an answer that's a bit more complex. So in terms of fibroid treatment options and fertility, the truth is that at this time, the best data is only limited to myomectomy. And as Dr. McConnell had mentioned, she had mentioned the different sort of routes of the procedure, whether it's hysteroscopic, laparoscopic, robot-assisted laparoscopic, or open. And there is ample evidence that myomectomy is safe in women who desire future fertility. So that is currently our gold standard for women who want to conceive. Now, there are other treatment options with some limited data, and the data is at this current moment limited to case reports, case series, and so patients who have undergone other treatment options, for example, fibroid radiofrequency ablation. I'm not sure if you've heard of it, but essentially it is a procedure where heat energy is delivered to the fibroid. And so there are currently in the United States 2 different ways of administering that heat ablation. So one is a transcervical, so meaning everything is through the vaginal route transcervically. And then the other option is the laparoscopic route for radiofrequency ablation. So that is sort of a bit more current. So it has been around probably, certainly in the last 10 years or so. So there is some limited data about patients who had that procedure who happened to get pregnant. But it's important to understand that the original studies actually excluded women who wanted to conceive. So at this current time, we recommend it for patients who do not desire fertility, but with the exception of some non-FDA approved way of allowing certain patients to have that, and making sure that they understand that there is limited data. And same goes for uterine artery embolization, which has been around for a little, bit longer, but again, similar to the RFA, the data is also limited to case series, et cetera. And there are some negative potential consequences of having, uterine artery embolization, including, placental attachment issues. If you sort of think about it, the way that uterine artery embolization works is that you deliver these sort of little beads to block off the blood supply to the uterus. And what does a pregnancy, what does like an embryo or need? A pregnancy needs blood to give it the appropriate nutrition, et cetera. So, there are some consequences of uterine artery embolization, and it's not necessary. It's highly debated in terms of this pregnancy issue, because people have been able to get pregnant after a uterine artery embolization, but the safety and the actual percentage, the data is not necessarily available.
Understood. And I'm sure that on a case-by-case basis, it varies, because where every woman's fibroids are located, the size of those fibroids, the age of the patient, those are all variables that I'm sure that you're evaluating very closely before recommending a plan of action for that particular patient. Would that be correct?
Yeah, absolutely. And I'm sure Dr. McConnell probably sees patients who may have had other procedures like uterine artery embolization who decide to get pregnant. I don't know if you have any further insight.
I have seen several patients who have had the uterine arterial embolization, and in those patients, they do not tend to do well. A lot of times the endometrial lining is compromised. As Dr. Kim mentioned, you have to think about blood flow. So the whole idea of the procedure is to try to decrease blood flow that's going to the uterine fibroids. And then at the same time, by doing that, you're also decreasing flow that's going to the eventually to the endometrium itself. So for that reason, we tend not to, if a patient presents to me requesting a procedure to help with fibroids, help with their heavy bleeding, I'm definitely going to point them in the direction of a surgical procedure. We wish there was other things that you can do besides surgical intervention that you can offer patients, but unfortunately right now, that's all we have that has shown that gives the best results. And it's been very good results showing good pregnancy rates after a myomectomy, anywhere from 45 to 49% of patients who have had fibroids and decided to get pregnant will do well. Now, of course, that also depends upon what other medical or infertility issues that they may have as well.
I'm so glad that you made that clarification. Thank you so much, because here in the Washington, D.C. metro area, there are frequently advertisements on the radio for embolization. And I think it's so important for our community members to be aware of the outcomes for that particular procedure so that they can evaluate it correctly and see if it's really a good fit for them, for their bodies, and for their goals. And you mentioned, Dr. McConnell, egg retrieval. Can that be done during another procedure?
What we tend to do if a patient presents stating and they know they have uterine fibroids and they really would like to conceive, a lot of times, depending upon the location of the fibroids, we will recommend trying to do a IVF procedure for them prior to doing a myomectomy. But unfortunately, there are some patients who present for infertility treatments or preservation because of the fibroid location and the size. A lot of times those patients will have to be referred directly to the GYN doctor for a myomectomy prior to, because the fibroid sometimes can be so enlarged it interferes with the route to be able to do the retrieval of their eggs.
Again, very helpful. Thank you very much. And sometimes it's a concern that a vaginal delivery will not be possible after a fibroid surgery. Is there data on that specific instance? I'll go to Dr. McConnell first.
I think Dr. Kim may be able to
Oh,
answer
okay.
that.
All right.
But what we have seen, what we used to say years ago, was that if you had a myomectomy and the fibroids were not close to the uterine cavity, or definitely if the uterine cavity was never entered, that those patients could potentially have a trial labor. However, if fibroids are involved in the cavity or very near the cavity, it is always recommended to consider a cesarean section for the fear of uterine rupture.
Okay. And Dr. Kim, I'll come to you.
Yeah. I mean, at the end of the day, I think most OBs would agree you want a healthy mom and a healthy baby. And what Dr. McConnell mentioned about uterine rupture is when the old incision on the myometriums, which is the muscle wall, opens, and that can happen with not just labor and the contraction of the uterus, but just as the uterus expands with the pregnancy, sometimes, that can happen as well. But luckily, it's a very It's not a frequent occurrence. It's a rare occurrence. However, when it does happen, it's just so detrimental, obviously, to the woman who might have internal bleeding, and obviously for the pregnancy, the fetus itself as well. And so it is a situation that most OBs would want that number to be 0. And so I think this topic is also a bit debated. But as Dr. McConnell mentioned, if, let's say, your fibroid was actually subserosal or pedunculated, meaning sort of on the outside of the uterus, and there was really no entry into the muscular wall, which is the area where you have the contractions happen, then I think, vaginal delivery, I think most OBs would agree that vaginal delivery is indicated. And then just the counterpart is if there's definitely entry into the uterine cavity, like Dr. McConnell said, it's as if you already had a C-section. And so most people would agree that, you definitely need a C-section. It's that in-between part where sometimes fibroids are in the muscular wall, and, whether it's 50% in the cavity or 80% in the cavity, or maybe it's just 20% in the cavity. I mean, there's unfortunately no a concrete data to suggest, oh, in this case, you have to do, a C-section. But I would say, in this, like I said, healthy mom, healthy baby goal, and potentially like legal implications, I think a lot of providers might be recommending C-section at the time of delivery if there's any sort of myometrial involvement. And I think that is our safe practice, is to recommend a C-section if there's any intramural fibroids that was taken care of, from the outside. So laparoscopic, robotic, open. But if one had received a hysteroscopic procedure, that means sort of shaving off the uterine fibroid from the internal aspect. And that means that, probably a decent portion of your fibroid was in the cavity itself, and either minimal to some portion was in the muscle wall, but that still means that you have intact muscle outside of that fibroid. So I think most providers would allow a vaginal delivery if one had a hysteroscopic myomectomy. But again, I think it's sort of, I think nationally there's probably going to be a debate, and I think there's some, studies, whether questioning, just sort of pushing limits of, how can we safely do a vaginal delivery in instances where people have had a laparoscopic myomectomy. Maybe the myometrial involvement was little, but again, there's limited data, so can't give a concrete answer. But for safety reasons, I think a lot of time you might hear from your provider, you need a C-section.
Very interesting. And
Yeah.
is there imaging that can show how much the fibroid has protruded into the interior of the uterus or the outside of the uterus?
Yeah, I think the best imaging is MRI. So whenever we consider myomectomy, we usually obtain an MRI for surgical mapping of the fibroid. Sometimes, although ultrasound is an excellent imaging modality and a great screening modality, when it comes to myomectomy, and we need to definitely be able to know the exact location of the fibroid as it relates to the endometrium, the myometrium. And so, and sometimes it can also pick up other smaller ones that may not have been detected on ultrasound. So I think with the MRI, you can certainly have a better sense of what percentage of the fibroid is actually in the cavity versus in the muscle wall. But there's also a saline ultrasound, where if the fibroid is majority in the cavity, like that is also another imaging study to detect how much of that fibroid is in the cavity. So different imaging modalities that show us different things.
Thank you for clarifying that. I remember before my third surgery, my physician recommended an MRI, and that was the first time I had ever heard that recommended, and it was just really comforting to me to know that he could see in such great detail what shape my uterus was in, how large the fibroids were. So that's really important information. So last question, is there other important information that you would like women and menstruators to know if they're planning to have a baby? Dr. Kim, I'll come to you first.
Mm. Well, I think, as you may have already heard from sort of our discussion today, sometimes the recommendation is never so concrete. It's there's sometimes a gray zone where maybe as practitioners and the medical field, we just don't have enough data. I do frequently also get some referrals and questions about whether women should just keep their fibroid and try to conceive. I think that's, I think just going back to your original question about which fibroids, what fibroid treatments can you potentially prepare a woman for pregnancy? I think one option is no surgery. I think that is one option as well. And I think the ones that, we know that need treatment from the fertility aspect, and Dr. McConnell obviously is much better equipped at talking about this too, but the ones that involve the uterine lining certainly have been shown to be an issue with fertility. So we know that, that's definitely something that needs to be taken care of if you have a submucosal fibroid. Now, I think sort of more that's coming to light are what we call the FIGO type 3 fibroids, which I know it just sounds, it's a lot of medical terminology, but essentially these are fibroids that are mostly in the muscular wall that come up to the uterine lining. And so the FIGO classification has reclassified these type 3 fibroids as submucosal. So having an effect potentially on fertility. So there's more more attention being put on to these FIGO type 3 fibroids that they may actually be an issue with fertility that might need treatment.
Thank you. And just for our listeners, FIGO is the International Gynecology Organization, and they established a scale for uterine fibroids. And so that's what Dr. Kim is referring to. I'm sorry, Dr. McConnell. And would you, are there other important pieces of information that you'd like women and menstruators to know if they're planning to conceive?
I just want to make a comment with regarding what Dr. Kim has said with the fibroids that are what we classify as a 3 for the FIGO score. And she said that's very controversial. Even though these fibroids may not be distorting the cavity as much, there's some literature to support that these fibroids may have some type of alteration of the expression of genes that will help with implantation of embryos. So knowing that fact and knowing that fibroids can increase contractility, causing patients to have maybe a miscarriage or preterm labor. I think it's important for the patients to really talk with their doctor when they have the fibroids and could discuss what all the potential issues may be so that they can make an informed, educated decision on what they would like to go through. As she mentioned, it is so controversial and everyone, it would be great if we just had a specific fibroid, we're going to do this, but we have to individualize every patient with how they're presenting as to what is the best treatment option for them. And I do encourage patients to please see their primary care doctor and their gynecologist for routine care and to monitor the growth of their fibroids, because it is unfortunate sometimes that patients many times fibroids are asymptomatic. They have no abnormal bleeding. The fibroids are not causing any discomfort, but all of a sudden you have these large fibroids. Now you're ready to get pregnant and you're wondering, oh my gosh, I never knew they were there. So if you are definitely in touch with keeping up with your routine care for yourself, I think that will be beneficial.
Agreed. Thank you so much. This has been so informative. And I'd like to add to our viewers to please vet your physicians and providers carefully, because you want them to have the knowledge that Dr. McConnell and Dr. Kim have expressed today, and along with the bedside manner, so that you can be assured that you're in the best hands possible. So with that, I'd like to thank you both for joining us today for Fibroid Awareness Month. We really appreciate it. Thank you for joining us today for this important conversation. If you're facing a menstrual health challenge, you don't have to make that journey alone. We encourage you to reach out to us at fibroidfoundation.org. As part of our Fibroid Awareness Month series, The Fibroid Maze, please join us on July 30th, 2024 at 7 p.m. Eastern for Fibroids After 40. We look forward to continuing to share powerful, informative, and enlightening conversations with you. Together, we are making a difference. Thank you and be well. Thank you so much for joining us during Fibroid Awareness Month for these important conversations. If you're facing a menstrual health challenge, you don't have to make the journey alone. We encourage you to reach out to us at fibroidfoundation.org. If you've missed any of these informative conversations, you can view them on our website, fibroidfoundation.org/events. We look forward to continuing to share powerful, informative, and enlightening conversations with you. Together, we can erase the stigma of silence around women's menstrual health, and together, we can make a difference. Thank you and be well.